Good evening and welcome to the TOGA Post-World Conference in Lung Cancer Symposium. My name is Rebecca Tay. I'm a medical oncologist at the Royal Hobart Hospital and Icon Cancer Centre. I also co-chair the TOGA Small Cell and Mesothelioma Working Group. It is my absolute pleasure to chair this evening. WCLC is really a highlight on the lung cancer conference calendar. Representing a multidisciplinary nature of the conference, we have 4 experts in lung cancer speaking to us tonight. We have Dr. Andrew Pattison, Associate Professor Mal Itchins, Dr. Tony Mersiades, and Dr. Neil Wallace. And I look forward to hearing their insights in respiratory, medonc, and radonc highlights. Before we start, TOGA would like to acknowledge the traditional custodians of the lands across Australia on which we live and work on. We pay respect to elders past, present, and future. We also acknowledge Maori as Te Ngāta Whenua of Aotearoa, New Zealand, as treaty partners with the Crown. We would like to thank our sponsor for this evening, Medicine, for their support in running this webinar. TOGA's joint vision and mission is to eliminate thoracic cancers. If this resonates with you, TOGA represents the full range of disciplines involved in lung cancer care, as well as our important consumer representatives. So please join us in running world-class research. So this is our agenda for this evening. I'll introduce each of our speakers just before their presentation. We would really love this symposium to be as interactive as possible. So there's plenty of opportunities to ask questions, and if you enter that in the chat box on your screen, we will have our discussion at the end of the presentations. So to take us through respiratory medicine highlights from this year's WCLC, I'd like to introduce Dr. Andrew Pattison. Andrew is a respiratory physician at Sunshine Coast University Hospital. He is the clinical lead of interventional pulmonology there, as well as chair of their lung cancer MDT. So thank you so much, Andrew, for presenting.
Thanks, Beck, and thanks for the introduction, and thanks for the opportunity to speak. So I'm going to run through 4 abstracts that were presented at World Lung with a respiratory flavour. There was a fairly heavy focus on lung cancer screening at World Lung. So 3 abstracts will be related to screening in various forms. And as we didn't have a surgeon to present tonight, I thought there was one interesting surgical abstract presented in one of the main plenaries. So I've taken the opportunity to also discuss that abstract as well. So the first screening abstract was out of the UK, looking at essentially what is the ideal upper age limit for lung cancer screening. Should we go higher than the accepted limits that we currently have from the landmark trials that we largely reference? So as we know, the large landmark trials, the NSCLC and Nelson, excluded patients over the age of 74 from screening. Despite that, across the world, we have different age cutoffs. In Australia, we have one of the younger age cutoffs of 70, working all the way up to, in the USA, they screen to age of 80. And despite those differences, we know that, at least in the UK, based on their data, that the average age of lung cancer diagnosis is age 74. So we will miss many cancers in the older age group if we stop our screening at an earlier age. So the data they looked at were looking at 2 main cohort studies, the Yorkshire Lung Cancer Screening Trial out of Leeds and the Manchester Lung Health Check, both with large numbers of patients. They ran a community-based mobile screening program in both sites. And they used those 2 cohorts and combined them and then separated the population into 2 groups. One was the younger group, aged 55 to 74, and then an older group aged 75 to 80, looking primarily at overall survival from diagnosis and also what treatment they received. So if you purely look at bang for your buck in terms of picking up lung cancers in different age groups, we can see that in the older group, we do pick up more cancers per screen, 2.8% versus 1.7% in the younger group. If we then look further into stage distribution between the two groups, there was an equal stage distribution with the majority of patients diagnosed at an early stage as expected. Some differences are then seen in treatment intent. So younger patients were more likely to receive curative intent than the older group, although still over 80% received curative intent treatment. And as expected, the surgical resection rates were higher in the younger group. So the primary outcome, if you look at overall survival, screening an older versus a younger group, as expected or somewhat expected, the older group has a poorer overall survival of 56% versus 66%. Interestingly, in subgroup analysis, however, if you look at patients that got to surgical resection, the overall survival was the same between both groups at over 80%. And further subgroup analysis found that essentially only those patients who made it to surgery had equivalent overall survival as the younger screen group. So if you look at patients having curative intent treatment or surgery or SBRT or diagnosed at an early stage, all of those other subgroups had poorer overall survival than the group aged younger than 74. So conclusions from that study was that there is a higher cancer yield if you screen in a higher group, at least per screen. There is, as somewhat expected, a higher all-cause mortality in the older group, but surgical patients in the older group had the same overall survival as the younger group. So implications from this study, the questions are, should we increase the upper age limit? And if we should that only apply to patients eligible for surgery? A difficult question is, at the time of screening, how do you actually identify those patients, which I think is a difficult question and hasn't been clearly answered as yet. And then the other factors that weren't really considered in this study is what's the cost and effectiveness of screening that patient group. Regional epidemiology differs between screening locations, which obviously has an effect, and also system readiness for screening a vast number of more patients per year. The second abstract is out of Taiwan. So this is the preliminary results from the Taiwanese National Lung Cancer Screening Program. And their program is unique in that they screen both smokers and non-smokers with a family history of lung cancer. We know that the epidemiology of lung cancer in Taiwan is very different from our population in that 60% of all lung cancers diagnosed are in non-smokers, and EGFR mutations are present in the majority of lung adenocarcinomas. The TALENT study, which has been published in the last few years, did show that in a population of never smokers with an additional risk factor, the detection rate of lung cancer was 2.6%, which is much higher than the landmark trials that led to screening in most countries. And the significant risk factors from that trial included a female sex and also a family history of in first-degree relatives of lung cancer. So from that data, the Taiwanese lung cancer early detection program was launched in 2022. Similar to our program, it's second yearly low-dose CT scanning. The first group screened is those that are current or former smokers with a 20-pack year history. But then the second group is patients who are non-smokers with a family history of lung cancer, screened at a younger age than most screening programs. So their early data in the first 2 years shows that patients with a family history of lung cancer actually make up more of the screening population than heavy smokers. The detection rate of lung cancer in the non-smoking family history group was higher than the heavy smoking group, 1.7% versus 0.8%. And more patients in the family history group were diagnosed at an early stage. So stage 0 to 1 diagnosed in approximately 90% of patients compared to 66% in the heavy smoking group. And to delve into that a bit deeper, you can see on the right, this was the stage distribution before screening was started in 2021, about 30% of patients diagnosed as stage 1. Following the screening program commencing, 74% are now diagnosed as stage 1. But if you divide that up into the smoking group and those with a family history, there's a bigger stage shift in the family history group. So this is some projected mortality reduction numbers from which is AI generated. So this is not a randomized controlled trial by any means, but you can see that the AI generated numbers show a vast mortality reduction in the family history group of 67% versus 36% in the smoking group, which obviously compares favourable to the randomised trials that have governed most screening programs to date. So what can we take from this study? Well, screening of non-smokers with a family history versus heavy smokers does give a higher screen detection rate, does seem to result, at least in this population, of a greater stage shift to early stage diagnosis and potentially a higher mortality relative risk reduction based on AI-generated projections. The difficulty is, can we extrapolate this data to other screening regions, including our own, with varying lung cancer epidemiology, which is an ongoing area of discussion. Outside of the Taiwanese study, this was also a trial discussed at World Lung. So this was out of the US in New York and Boston centres, looking at screening female Asian non-smokers, whether they had a family history of lung cancer or not. And it's in its early stages, but the preliminary results show that over 1,000 patients have been screened, a screen detection rate of 1.3%, so not as high as the Talent study, but still higher than the NLST data. And interestingly, all patients diagnosed with cancer did have a driver mutation, either EGFR or HER2 in that population. So there is some data emerging outside of Asian countries. So this is Australian data, really interesting and somewhat provocative study, I thought, out of Curtin University, Fraser Brim's group, looking at the cost effectiveness of our screening eligibility criteria and comparing it to other screening criteria in existence. As we know, there's, I guess, two methods of lung cancer screening in existence. One, a categorical model, so the US criteria and our criteria are two examples of those. So MSAC, the Medical Services Advisory Committee criteria. And then you have risk prediction models, which incorporate categorical criteria, but also other risk factors to detect a 5 or 6 year risk of lung cancer. We know that the International Lung Cancer Screening Trial, which had sites in Australia, did show that a predictive model, in this case the PLCO model, did result in a higher detection rate than the US categorical criteria. And from that, the lung cancer screening inquiry did suggest incorporation of PLCO into our screening program. However, as we know, the Medical Services Advisory Committee, following that recommendation, still elected a categorical screening criteria for various reasons. So the question from this study out of Perth was, how does our criteria perform in cost effectiveness, especially in comparison to other eligibility criteria? So what they did was look at a micro-simulation model. So this was a simulated population of 10,000 participants, and then applying different criteria that I've mentioned earlier, so categorical and risk prediction models, to that population, and then looking at how many patients would have been screened from that population and looking at cost effectiveness in terms of life years gained. So the results show that the MSAC criteria, in comparison to other criteria, screens a lower proportion of the simulated population. So 37% versus, say, 52% for the PLCO criteria. And importantly, achieves less of a stage shift towards early diagnosis. So only 11% achieved stage shift in the MSAC criteria versus higher rates in the other criteria I've mentioned. I'll just take you through this diagram. So this is looking at cost effectiveness, and it's looking at all the different criteria that I've mentioned. And along the x-axis, you have willingness to pay threshold, and on the y-axis, the probability of cost effectiveness using different willingness to pay thresholds. The MSAC criteria is sort of the mustard-coloured curve. And you can see that compared to all of the other criteria, irrespectiveness of what your willingness to pay is, the probability of cost effectiveness is actually less. So compared to the Liverpool Lung Project criteria, the US data, or the PLCO criteria, it is less effective from a cost effectiveness standpoint. So the conclusions from the authors in this abstract was that the MSAC criteria performed quite poorly compared to other screening criteria in a simulated population, and that our criteria may require ongoing finessing and evaluation and adjustment in the future. And the final abstract I'll discuss is the surgical trial. So this was a trial out of the UK. It's a meta-analysis of randomized trials looking at survival outcome of VATS compared to open lobectomy for lung cancer. So as we know, VATS has had widespread adoption as the main approach for lobectomy in early stage lung cancer. And while that's the case, most of that is based on the non-oncological benefits, such as less pain, fewer complications, and improved quality of life. And the assumed oncological equivalence is essentially that. There hasn't been a single randomized controlled trial that's actually been powered to detect a difference in overall or disease-free survival. So what they look to do is run a meta-analysis of RCTs that ask that question, and then look at overall survival and disease-free survival. 3 trials met that criteria from Denmark, China, and the UK, respectively. Over 1,000 patients included, with an equal distribution between VATS and open lobectomy, varying follow-up times across the 3 trials. In terms of the primary outcome, which is overall survival, to my eye, the curves look pretty tight, but there was a significant difference, with overall survival significantly favouring VATS lobectomy with a pooled hazard ratio of 0.79, and that reflects a 21% mortality risk reduction. The secondary outcome of disease-free survival showed no significant difference between VATS and open lobectomy. So conclusions from this abstract was that VATS compared with open lobectomy appears to improve overall survival without compromising disease-free survival, which is important. The question of why there is an overall survival benefit potentially comes down to non-cancer specific outcomes. Some of those trials did report a lower readmission rate post-VATS compared to open lobectomy, and reduction in adverse effects over the first year. Fortunately and luckily for our practice, it reaffirms our position of prioritising VATS lobectomy when technically feasible. So I'll leave it there, Beck, and I think we'll take questions at the end.
Yeah, thanks so much, Andrew. It's amazing to see expansion of some screening programs to include sort of non-traditional risk factors like family history. We might, in the interest of time, move to the next presentation, which is from Mal. So Mal Itchins is a thoracic medical oncologist at Royal North Shore Hospital and Chris O'Brien Lifehouse, very well known to us here at TOGA. She's also one of the co-chairs of the Advanced Non-Small Cell Lung Cancer Working Group. So Mal will take us through some highlights pertaining to oncogene-addicted metastatic non-small cell lung cancer. Thank you, Mal.
Thanks, Beck, and thank you, TOGA, for putting on another post-Congress meeting. I was fortunate enough, after a quiet few years, to have been at World Lung in Barcelona, and here are just some snaps of Chi presenting the Sherlock study, which was a TOGA-led study in an oral non-small cell session, and I'll take us through some of the headline results of Sherlock, and a number of co-investigators we know well there also in the photo. So here are my disclosures, and you may have seen I've entitled the talk really in the oncogene setting. The theme of World Lung is more better, and we've seen this mounting in the recent years. Rational combinations of therapeutics, and particularly in the first-line setting, all-comer combination data. So here are my ambitious abstract list, which I'll try and whiz to. FLAURA2, first-line Aussie chemo, mature overall survival across 2 Chinese data looking at the same combination of olmesartan, third-gen TKI with chemo, in those with higher risk phenotype of EGFR with tumour suppressor gene co-mutations. The COMPEL data was presented looking at the addition of chemo with continuing Aussie in those with EGFR mutant disease who progress outside of the brain on first-line osimertinib. The olmorasib with chemo-IO and pembro, LOXO data in first-line KRAS G12C, Sherlock as mentioned, and a novel antibody-drug conjugate, which is looking hot, Isabren for pronunciation purposes, a HER3 EGFR ADC, some really nice data in EGFR. So FLAURA2 was the opening plenary session looking at the mature overall survival. I guess we hazarded a guess it was positive for multiple reasons, including a press release a couple of months earlier. Just to refresh our brains, which probably don't need, FLAURA2, phase 3 study, first-line EGFR sensitizing mutations, randomizing 1-to-1 to Aussie chemo, platinum pemetrexed with maintenance pemetrexed indefinitely versus osimertinib, stratified by race, where the EGFR test was done, and WHO performance status. So a very, as expected, pragmatic phase 3 design, and overall survival was a secondary outcome, and at 57% maturity was expected to be read out for significance. So we saw the significant overall survival, a 10 months improvement in the median, statistically significant landmark at 3 years, 12% improvement in overall survival. And this is all comers EGFR mutant. So we looked at the forest plot of the hazards, and they all certainly favour. We've, I guess in the past thought about those high risk features we may select for a FLAURA2 approach, but really everybody benefited. There was a question in the discussion about what was going on with the Asian non-Chinese, and that was put down to small numbers and a subgroup analysis that we couldn't completely explain while that was sitting at Unity. So what was interesting in the first time we saw is the exposure, as we've all been grappling with the maintenance pemetrexed, which was built into the protocol. So what was interesting in the FLAURA2 protocol was actually PEMI, the median exposure was 8.3 months. So really those in the intervention arm had about 3 times more Aussie, which I guess those of us in the clinic like to see. We then saw for the first time the subsequent treatments, which was intriguing, and over 2/3 in the Aussie chemo actually went on to receive a next line of therapy, and most of those received chemotherapy. Half of them were re-challenged with platinum doublet, and I guess that's what we've been wondering, what we may do, in the circumstance of a FLAURA2 progression, of course, in those that have had a significant chemo-free interval. So again, just briefly, in the interest of time, we didn't see any new safety updates. Of course, adding chemo to osimertinib, we do see some more toxicity shown here on the tornado plot, more of the myelosuppression, a little bit more GI toxicity. And if we have time, we may discuss that in patient selection at the end. So then the conclusions really are this is a new standard of care. And I think that we were really waiting on these data. And this is actually, whilst we're waiting for the mature overall survival absolute readout from Mariposa, Laser, AMI first line, 47.5 months overall survival is the longest overall survival we've seen for EGFR, so it's really exciting. I guess, using a more potent approach up front, we get better objective response rate, less drop-off, better CNS control, we hope. What we are now hopeful for is some biomarkers to guide us, as at the moment, certainly looking at an amivantamab later line approach, MET doesn't seem to predict. Actually, everybody seems to benefit, for example, in Mariposa 2. Similarly, I think we're all hopeful for more adaptive trial design, such as in a phase 3 study, phase 2, I've listed down the bottom there, SHEDDA, which looks at, liquid positivity after induction osimertinib and adding chemotherapy in that circumstance of a higher risk phenotype. And they're difficult trials to do, but, I hope in the future we're seeing ongoing assistance in our selection of the optimal patients for a monotherapy or a more intense approach. So moving quickly to the next abstract that was read out after FLAURA2 was ACROSS2, which is a Chinese phase 3 study that looked at the Chinese third-gen olmorasib with chemotherapy and those that were tumor suppressor gene positive. So this abstract didn't tell us how that was defined in liquid or tissue. Down there in red, it listed TP53, which is the lion's share of tumor suppressor genes, but a whole host that can be positive and a poor prognostic. It was powered actually to show a hazard ratio of improvement ambitiously at 0.5, so needing about 120 patients on the study. So we did see an improvement, p-value 0.2, hazard ratio 0.55, about a 3-month improvement in overall survival in those with positive co-mutation profile. They read out the TP53 population, which had a similarly almost 3-month improvement. We didn't see more granular data on the other tumor suppressor genes, but that was also positive. You know, because I guess, as I alluded to, I mean, in FLORA-2, we were quite interested if that's an important population, those TP53 positive, about 30% at diagnosis with EGFR mutation, you know, whether they may be the group, you know, with hazards that suggested we add chemo. We haven't seen that bear out sort of more significantly in the small numbers in FLORA-2, but we did see it predictive in a subgroup analysis in Mariposa. But the discussant around this abstract really did speak about, at the moment, TP53, you know, is certainly a negative prognostic, and we've still got some work to do with sort of combination type approaches to try and lift the bar in this group. There's another study which will give us more clarity, an international phase 3 study here, very similar design, larger numbers, particularly TP53 focused on the top study, which we'll look forward to. So the COMPEL data we've been waiting on, and I won't mention too much, but perhaps some of us in the clinic have tried to adopt this approach in the absence of those progressing on osimertinib, us having great options. And what it basically did was it looked at a randomized control study of adding platinum doublet chemotherapy to osimertinib, as I mentioned earlier, in progression of those who had PD outside the brain versus chemo alone. It was mentioned, given the busy landscape in this space, a lot of ADC trials in particular, this study was unable to recruit its original cohort size. It reported on 98 patients, and so it was a descriptive analysis of the findings of those 98 with a primary outcome of PFS. What wasn't mentioned in the abstract, although MRI brain for surveillance on the study or for monitoring was preferred, we didn't hear how many actually went on to have MRI brain whilst on trial. So just to look at the results, so to mention, going on study, as I said, you kind of progressed in the brain, about 22%, so a small number had pre-existent CNS disease. So most didn't have CNS disease going on to COMPEL. I think the results are compelling. So PFS in all overall intra and extracranial, you know, doubles. So that looks pretty nice, doesn't it? Non-CNS progression, interestingly, because these individuals had progressed already outside the brain, was also significantly improved, 5.2 to 8.4 months. CNS PFS, which is such an important outcome for these individuals, you know, was also substantially improved out to 15.9 months. Of course, the caveat is small numbers, and overall survival as well. You know, certainly there's a signal here that this looks to be an appealing strategy. You know, at the moment, not one that we can do via Medicare. Now, I haven't mentioned the safety in this one, you know, again, in the interest in time, but I guess osimertinib and chemotherapy we've seen in FLORA-2, and I guess in the clinic, we hope to have increasing exposure on managing, you know, this combination. So I guess we need to think about COMPEL against Mariposa 2, so AMI chemo, which is a protocol we hope to have Medicare reimbursed in the not too distant future. Again, you know, a randomized powered phase 3 versus a descriptive analysis. But this does actually stack up reasonably well with regards to PFS, 6.3 months, Mariposa 2, 8.4, and grade 3 TRAEs, I think, you know, really they're those myelosuppression AEs, which of course are important, but perhaps manageable. So I thought this was really interesting data. And so then moving on to olmorasib, which is a second generation KRAS G12C inhibitor. We've seen data in previous conferences leading into World Lung. We saw three important readouts of new data, which is basically pulled data from the phase 1 cohort study, as well as the lead-in safety data of the phase 3 Sunray 01. So initially in the first line setting, KRAS G12C, we saw the Pembro chemo olomorasib data, which was for all comers PD-L1. So down here you can see that there was a good representation across the board for PD-L1, including a third that were not PD-L1 expressers. What I liked about the design of these trials is it was quite pragmatic in that you could have started chemo IO whilst you were screening for the study. I think KRAS G12Cs can be hard to get on trials, and about a third on this in this readout of 70 odd patients, they did. So I guess what we're seeing here in the waterfall plots is a really nice signal for response. So, you know, across the board, objective response rate 60+%. You saw responses irrespective with chemo IO KRAS G12C inhibitor in all PD-L1 expression subsets. You also saw good responses in the 2 doses that were being investigated at that time, 50 twice daily and 100 mg twice daily. So I think we see the snapshot there that this is certainly active. Duration of response, not yet mature. So I've just popped this up really to show that, you know, this is going to be intriguing to see what we start reading out for efficacy. So again, the combinations, obviously, we need to scrutinise. I mean, there's four drugs, counting the 2 chemo agents here. So just as a sneak peek, 18% did require a dose reduction of olomorasib, and 7.8% discontinued. There were only a couple of cases of pneumonitis, which is always where we sort of look to next. As expected, the myelosuppression, you know, when I looked across the board, the next one would be the transaminitis. So a few do get grade 3. It looks with the stringent protocol manageable. You've just got to decide which drug you're stopping, but I think that was all very clearly defined in the protocol. So then moving on to, so Melissa Johnson then presented the olomorasib with Pembro, so the non-chemotherapy containing regimen in about 85 patients. And this was actually also irrespective of PD-L1 expression. But however, about 2/3 actually in this cohort did have PD-L1 50% or higher, and you can see that in the blue bars there. So it was really a heavily enriched population, but objective response rates in a chemo-free schedule of 73%. So this is looking, I think, really hot. And again, you know, looking at the tolerability in the schedule that doesn't have chemo, we don't see our usual chemotherapy AEs here reported, but you still did see similar discontinuation rates, I guess, with the IO TKI combo, 2 cases of pneumonitis, you know, and again, it's the GI and transaminases, I think, with this schedule needed. So this protocol is being carried forward to the Sunray 01. And what I didn't mention, and I need to, is Brian Chan, our friend and colleague, was a co-author on this particular abstract. And then that's really naughty of me because Chi Lee was the senior author on Flora 2. So I've missed out acknowledging our Australian colleagues, and I'll try and make up for that. So I think Sunray 01 phase 3 is in a number of different states recruiting at the moment. It's had FDA breakthrough designation for high PD-L1 KRAS G12Cs at the moment, and I think that'll expand. Interestingly, they've carried forward the 100 mg BD dose, and they're looking at the non-chemo schedule only in a high PD-L1 population. So Sherlock, as I mentioned, a TOGA study, I think everybody should be very proud of, including Chi, who led the study, and Serene, whom was the co-chair. So this was a single-arm phase 2 run throughout Australia, looking at KRAS G12C treatment naive, looking at sotorasib first-gen TKI with chemo and Bev backbone, continuing then maintenance, Soto, Pemi, Bev. There are a number of caveats to being bevacizumab eligible for the study, also around, for example, blood thinning requirements and stability of various comorbidities leading in. 52 patients went on, a usual KRAS population. I think interesting, a few more females, 62% in these numbers. Brain mets were represented, a good spread of PD-L1, and liquid was interrogated for some of the important co-mutations that may, I guess, predict for an immune cold phenotype, STK11, KEAP1, and TP53. So the primary outcome was objective response, 64%, which is good. Again, as I've mentioned, these can be a difficult group of patients molecularly with their biology. Duration of response, 7.5 months. Intracranial response, 30%. So we saw responses across the board nicely, irrespective of the PD-L1 expression. And then we saw a median progression-free survival, 9.1 months, a respectable median overall survival, 25 months. In the small numbers available, there was some, I guess, a look to see what happened based on the co-mutations, whether there was 1, 2, or 3, and they all performed quite similarly, as I guess this is a group where we're still understanding the value add of immunotherapy. And then importantly, with regards to the tolerability, I think it was as expected as per the therapies that were utilised. I guess one note that certainly did come up in the discussion time was, again, in the numbers, there were 5 deaths, 10%, and perhaps a couple here we could see that the bevacizumab may have contributed to. So this was something, of course, that was noted if this type of a schedule was carried forward, to proceed with caution. So I guess with regards to immunotherapy schedules ongoing and trials in the KRAS G12C, we've seen some complementary data in some studies listed here that have been consistent with Sherlock. Codebreak 202, I think, is a study we're looking forward to, phase 3 Amgen study, which looks at the non-PD-L1 expressing, population with SOTO chemo. So again, I think that there are thankfully many KRAS G12C first-line studies available. I have listed some here. We've mentioned Sunray. I think the Candlelit, the MK1084 study is looking really good as well in a number of states. And I think the DS3001 asset is also looking very active. So hopefully we can get more of our individuals on also these industry studies. So in the last minute, or 2 minutes if I can borrow one, Beck, is the EGFR mutant HER3 ADC Isobren, as I mentioned. I think BMS may now have a little bit more to do with this therapeutic, or may even own it. So this has had FDA breakthrough designation actually around the time of World Lung for those EGFR mutants pre-treated. So I'm going to present two lots of data in a couple of slides, just looking at the efficacy of the monotherapy of this ADC post-osimertinib, then looking at it with osimertinib in a sort of fluoro2 extra type approach. So this ADC is actually a topo-1 payload, but it's a novel linker that is expected to be more permeable and have more of a bystander effect, is sort of what was discussed. So perhaps, be good for some of the, the molecular heterogeneity of some of these cancers, particularly drug resistant. So here's just the headline data and the results of what we saw. So we saw in the treatment naive, we saw a 12-month progression-free survival with the combo of 92%, objective response rate of 100%, and too soon to see mature efficacy. In those that have only had Aussie, we saw a median PFS of 12.5 months, obviously small numbers, but benchmark Mariposa 2, 6.3. So we're pretty interested. And then those that have had Aussie and then chemo, more pre-treated again, median PFS, 12 months. So this is looking active and really interesting, and hopefully it speeds through its investigation. Here's just the visual. So I'm more of a visual person, so hopefully you'll see the objective response rates in those post-osimertinib shown here, 56%. PFS, as I said, 12.5. OS yet to be reached. And again, objective response rate 100%. It sort of speaks for itself there in the treatment naive. I would say there's a couple of different doses that have been carried forward also for safety. This is a day 1, 2.5 mg per kg. So of course we need to see more of tolerability. We know the alopecia, the asthenia, the stomatitis with ADCs needs some serious attention in the clinic. Didn't see too much of a pneumonitis concern, but we'll see how that bears out. But yes, we'll watch with interest how this is being tolerated. So I think I'm done. It's just frozen. So this is going forward to phase 3, a global phase 3 post-osimertinib, and in China they're doing a phase 3 first line, which makes complete sense. So I think in conclusion, yes, more does look better for survival. We need better biomarkers to select our individuals. CNS control is paramount, and I think that argues doing more early. Tolerability is a big consideration and can be a trade-off. And our access in Australia is still evolving in this space. So thank you. And I think the final thing I would say is the best part about any of these meetings is obviously getting together with colleagues and sharing the love. So there's a few happy snaps from World Lung. We had a great Australian contingent there. Thank you.
Thank you so much, Mal. I think those photos are great incentive to join everyone next year, I think, in Korea. So, and congratulations on Dynamalc as well. I think and it's great to have so much Aussie representation at World Lung. Looking forward to sort of unpacking the EGFR space in the discussion. We might move on to Dr. Tony Mersiades, who's going to present highlights in small cell as well as locally advanced non-small cell lung cancer. We've given you a very big topic, Tony. Tony is a medical oncologist at Northern Beaches Hospital. He's also a PI on a number of clinical trials, as well as being a research fellow with the NHMRC Clinical Trial Centre, where he works on the TOGA Clinical Research Program. So thank you very much, Tony.
Thank you, Beck. Thanks to the TOGA organising committee for asking me to present. So I have some disclosures. So I was a virtual only attendee. I'm only presenting one randomised controlled trial, and other than that, I have no relevant disclosures. So my abstract highlights in the small cell lung cancer space is presenting the Delphi 303 data, which is the longer term follow-up of the phase 1b of in extensive stage small cell lung cancer using maintenance tarlatamab in combination with maintenance PD-L1 inhibitor. Also ID8 Lung 01, which is a phase 2 second line plus extensive stage small cell lung cancer study of ifinatamab deruxtecan or IDXD at the 12 milligram per kilo dose. And then a new ADC in the M23385 study, a phase 1 in a similar cohort, and it's with the drug called ABV706, which is the CES6 ADC. I then switch gears completely and go to resectable non-small cell lung cancer and present the results of the NADIM adjuvant study, which is concurrent chemo plus nivolumab for resected stage 1B to 3 non-small cell lung cancer with a 6-month post-chemo IO nivolumab dose. And then I switch gears again, and this is really sort of a tantalizing thing, thinking about unresectable or borderline resectable locally advanced non-small cell lung cancer. So there was a decent sized retrospective multi-center cohort study which presented some outcomes. So in the interest of time, I'll get going. So IMPOWER 133 and Caspian are the 2 phase 3 randomized trials which have established etoposide chemo in combination with the PD-L1 inhibitor as the standard of care for extensive stage small cell lung cancer. So we get median overall survivals a little over 12 months, and unfortunately long-term survival is rare, so 2-year survival of around 22%, despite a very high response rate. This year at ASCO, we heard the results of IMFORT, which is a phase 3 randomized trial which looked at adding the chemotherapy agent lurbinectedin to the maintenance atezolizumab part in the same population. So this study did not allow people with CNS metastases on, and also the randomization happened after 3 months of chemoimmunotherapy induction. So you kind of have to add 3 months to the end of everything. So nonetheless, it did show quite a significant improvement in median overall survival, 13.2 months, and the 24-month overall survival is about 30% if you trace off that. So this has I guess led to maintenance atezolizumab in combination with lurbinectedin as being a standard of care treatment option, but the drug cost and side effect profile we all think will limit uptake. Then we also heard at the same conference about tarlatamab as a second-line treatment for relapsed small cell lung cancer. And it's a bispecific T-cell engager which directs cytotoxic T-cells to DLL3 expressing small cell lung cancer cells. and it showed a significant improvement in median overall survival compared to second-line chemotherapy at 13.6 months. And the 12-month survival was 53%. Objective response rate's 35%, and the median duration of response was 6.9 months, but at 12 months, 41% were still responding, so it can be durable. So this led to really the inclusion of tarlatamab as a part of the maintenance strategy that was done with similar to IMFORT with lurbinectedin. So here we're seeing the safety survival update for the Delphi 303 study, which is a phase 1b trial that looked at adding tarlatamab to the maintenance PD-L1 inhibitor for the management of extensive stage small cell lung cancer. So to go on to the study, people had 4 to 6 cycles of platinum etoposide with the PD-1 inhibitor of choice. They needed to have not progressed. They were ECOG performance status 0 or 1. People with treated or asymptomatic brain metastases were permitted on this study, so that's different to IMFORT. And importantly, if they had had an active autoimmune disease or disease requiring immunosuppressive therapy, they weren't eligible. So this is not a randomized study. People went on to the same tarlatamab dosing schedule that we're used to, and any that had atezolizumab or durvalumab. So here we're really looking at the longer term results for this study. So 88 people were on the study in total. And the key things, I think, from this is that a quarter of people had brain metastases and about a third had liver metastases. And almost all of them, 88%, had had a prior PD-L1 antibody. With a median follow-up of 18.4 months, we got a good idea about what the long-term safety is like with this combination, and it was quite well tolerated in general. So there were about a quarter of patients had grade 3 tarlatamab related adverse events. There were dose interruptions in about a quarter, and 6% discontinued, so that's not too bad. We did see ICANS, but only in 6% of patients, and it was grade 1 to 2 and manageable. And we did see cytokine release syndrome as well in a little over half, but again, it was mostly grade 1 and 2. And as we've seen previously, the cytokine release syndrome really only occurs during cycle 1, day 1 and day 8, so in the first couple of weeks of treatment. The other thing that we saw is that the rates of the tarlatamab side effects, the dyschezia, the fatigue, the headaches, reduced appetite, nausea, and pyrexia, all reduced in incidence over time. The efficacy was the real showstopper with this. So the top left is a graph showing the overall survival with a 12-month overall survival of 82% and a median overall survival of over 2 years, so 25.3 months. We also saw that this happened despite the progression-free survival median being only 5.6 months. But those that did have a response or had a third of people were progression-free at 12 months. And you can see that those that did have a response tended to have a durable response. So on the bottom right, there's sort of a running tally of the response rates, progression-free survival, overall survival, and landmark time points of all 4 of these strategies. And you can see that the huge difference between the far 2 ones with maintenance tarlatamab and PD-1 inhibitor on the right is the 25-month overall survival compared to 13.2 months with lurbinectedin. So in summary, tarlatamab, addition of tarlatamab to anti-PD-L1 inhibitor as maintenance therapy for extensive small cell lung cancer was safe. It gave some sustained disease control and led to an unprecedented overall survival, including a almost doubling really of what our prior experience of this type of therapy is. So I'm now switching gear and looking at antibody drug conjugates for pre-treated small cell lung cancer, because there are a number of these emerging, and they do target DLL3 B7H3, CES6, or TROP2. And these are all expressed in greater detail on small cell lung cancers, and there may be some differences between the different subgroups of small cell lung cancer. So there were 4 abstracts to look at. I'm only going to talk about 2 of them, but I will summarize them all at the end. So the IDXD, there was a phase 2 trial which looked had a part 1 dose optimization component and then a part 2 extension, which added another 95 patients having the 12 milligrams per kilogram Q3 weeks dose. So this is combined data for all patients across parts 1 and 2 who had that dosage, and we got a median follow-up of 12.8 months. So patients who went on to this study had had at least 1 platinum-based chemotherapy and less than 3 lines of systemic therapy. And again, asymptomatic brain metastases were eligible. So the things to point out here is 38% had CNS metastases, 13% had a chemotherapy-free interval of less than 30 days. So these patients are not normally on these studies. They were also very heavily pre-treated. So a third had had a prior topoisomerase 1 inhibitor, 1 in 5 had had prior lurbinectedin, and 8% had had a prior T-cell engager like tarlatamab. So this is a very active drug. We saw response rates of around 50 to 55%. So in the second line setting, it was 56%. The disease control rate was 96%. And we saw it irrespective of baseline brain metastases, whether they'd had a T-cell engager or a prior topoisomerase 1 inhibitor. The responses were quite rapid, which you can see in the bottom left with the spider plot. So basically people responded on their first scan, and the duration of response was about 5 months. So the progression-free survival median was about 5 months, and the overall survival median was about 10 months. So looking at the subgroup analyses, there was basically similar response rates seen across all groups, with the exception of those who had the chemotherapy-free interval of less than 30 days, who only had an 11% response rate. From a toxicity point of view, the most common side effects were gastrointestinal hematological fatigue, and there was also some interstitial lung disease. So the grade 3 adverse events were mostly hematological, though. Having said that, there were 2.9% grade 3 adverse events and 1.5% grade 5 adverse event interstitial lung disease. So in conclusion, IDXD at this dose has remarkable efficacy in patients with heavily pretreated small cell lung cancer. And the confirmed response rate and activity we've spoken about. And it's important to note that at ESMO, we'll hear about the full subgroup analysis of those with baseline brain metastases. And there is an ongoing phase 3 ID8 Lung 02 trial, which is comparing IDXD at this dose to our previous standard of care chemotherapy, physician's choice. So the next ADC I wanted to present is the ABV706 ADC, and I want to acknowledge Lauren Byers and AbbVie for allowing us to present these slides, which were presented. So seizure-related homolog protein, or CES6, is highly expressed in small cell lung cancer. It's a neuroendocrine lineage marker, and there were some first-in-human study activity results presented in the neuroendocrine cancer cohort. So it's similar to other ADCs. It's got a topoisomerase 1 inhibitor payload, and it's got a stable linker attachment and a DAR of 6. So this study was similar in terms of the prior studies. It did allow patients with treated or stable brain metastases and prior exposure to a similar ADC or an ADC with a topoisomerase inhibitor was not permitted. So there were 2 doses in this dose optimization cohort. So patients were randomized to 1.8 milligrams per kilo or 2.5 milligrams per kilo, about 40 in each arm. And looking at the baseline characteristics here, we can see on the right that the main thing to point out is that 75% had received prior PD-L1 antibody, about a third had prior topoisomerase 1 inhibitor, and a small number had a prior tarlatamab exposure. So responses were seen across both dose levels, and actually the response rate in the second line cohort was higher at 81% in the 1.8 milligram per kilo dose. And we also saw high levels of response across the chemo-free intervals as well. And there was no association between the SEZ6 expression between the responders and non-responders, so it wasn't looking like we have a biomarker for this one either. So again, like with the other ADC, the responses were rapid and with some durability. So the winner in this is the 1.8 milligram per kilo in this at 6.2 median duration of response. And the progression-free survival was similar, but if you look at the 1.8 milligram per kilo dose in the second line setting, that was 7.5 months. So again, that was the winner. So the reason for the 1.8 milligram per kilo dose being the winner, I think, is explained quite well here. So there were higher rates of grade 3 treatment adverse events leading to dose interruption and dose reduction in the 2.5 milligram per kilo cohort. So that meant that the relative dose intensity was lower. So for this reason, in terms of side effects, what they were, it was mostly hematological in terms of the grade 3 plus adverse events, but there was also fatigue, nausea, reduced appetite, and dyspnea. There was also interstitial lung disease in 9% of patients, and the grade 3 ILD was seen in 2 patients in each arm. So that's so in conclusion, AbbVie's got a manageable safety profile and promising efficacy in heavily pretreated relapsed refractory small cell. And it's got high response rates, and it's actually the activity that we're seeing is similar to what you see in first line treatment with our standard chemo drugs, or it even makes me think of our tyrosine kinase inhibitors. So on the basis of these results, 1.8 milligram per kilo is every 3 weeks is the dose that's going forward. So this is a summary slide that of the current assets. On the left is the target that the ADC is targeting. The next column is the name of the drug, a little bit about what the drug involves, a number of patients who are in the studies, the phase of the studies. And I guess the key thing is towards the middle, you can see the objective response rates, which are sort of between 50 and 75%, the disease control rates, which are 80 to 95%, the median progression-free survivals, which are all about 5.5 to 7 months, and the overall survivals, which are generally 10 months or more. All of these drugs do cause some hematological toxicities. Some of them have GI tox and diarrhea as well. And we do have to look at the interstitial lung disease with all of our ADCs. So I've just listed the trials on the far right now that are ongoing. So I won't dwell on these, but just to say we do need to be aware that these studies are ongoing because we all have these patients and should be thinking about trials. So a summary of ADCs in pretreated small cell lung cancer is that they're showing very promising activity. There's a number of different targets, and phase 3 trials are planned or ongoing, but we don't really have much idea with predictive biomarkers yet. And it may be that the different small cell lung cancer subtypes, which have different variable expression of the targets, has some role in helping us pick the right drug for the right person. And it's also, we need to learn more about mechanisms of resistance. So I'm now switching gear again to Nadim adjuvant, which is resected stage 1B to stage 3A non-small cell lung cancer. It's a Spanish cooperative group study. Patients were randomized to receive 4 cycles of chemo plus nivolumab, followed by 6 months of nivolumab or chemo and then observation. So this is the first adjuvant non-small cell lung cancer study which has combined chemo and immunotherapy up front. The others have done it sequentially. And this was the first interim analysis. Now, some other things to point out, they tried to do optimal patient selection. So people who had known STK11 or KEAP1 mutations in their cancers were excluded in addition to the usual EGFR and ALK. And it also is the first study that has looked at shortening the duration of the adjuvant immunotherapy, which is something that's important for us to know. In terms of the baseline characteristics, they were balanced between groups. There was a slight imbalance in terms of cardiovascular comorbidities that might be relevant to some of the results. So that favoured the control arm. And you can see on the right that there's very few patients who had known KEAP1 and STK11 mutations. And the majority of patients, 80%, had a lobectomy. The other thing to say is the pathological stage is predominantly stage 2B and 3A, which is slightly lower in terms of stage than our neoadjuvant studies. So the disease-free survival after 34 months median follow-up maturity of data, 57% is not reached. But there is a separation of the curves. And if you look in the first 6 to 9 months, you can see that actually the experimental group does worse. And this is really down to the 6 patient deaths, which were largely cardiovascular in origin, according to the presenters. But it does make me think about what is the safety of doing this immediately after surgery. And what we can see is for the overall safety data, that there doesn't appear to be anything too unexpected for chemoimmunotherapy there, except for those deaths at the start. So the disease-free survival by a subgroup really didn't yield anything surprising. They did some sensitivity analyses using disease-free survival from the date of last chemotherapy, and that's really so that they can compare to other phase 3 trials like IMpower 010. And they also did a sensitivity analysis because of the deaths, looking at the disease-free survival with cancer-specific outcomes. And actually that did appear to show quite a big improvement in terms of the hazard ratio of 0.54. But this study hasn't met its endpoint yet, and it needs longer follow-up. So the overall survival is immature. They did some minimal residual disease work, but it was a protocol amendment, and it only is relevant to about 40% of the cases. And really the key thing that they've shown is that you appear to have better outcomes if you don't have minimal residual disease detected. So in conclusion, this study really addresses some important adjuvant non-small cell lung cancer questions around adjuvant chemoimmunotherapy concurrently, a limited duration of immunotherapy, and patient selection. And although we're sort of shifting to neoadjuvant, it does remain relevant because we do sometimes have surgically upstaged cases who then the adjuvant data is relevant to. The data are immature, so we do need to wait. But there was a trend towards reduced recurrence in the experimental group with about an 18% difference. And the 6 deaths, I think, is a is going to create some questions, and it may impact on the interpretation of the disease-free survival. So the other thing to point out is there's an Accio trial which is similar, but is using pembrolizumab as the investigational drug. So now moving again to the borderline or unresectable non-small cell lung cancer group. So the standard of care for stage 3 non-small cell lung cancer that's not resectable is chemoradiotherapy with or without adjuvant durvalumab, provided they don't have an EGFR mutation, and that's as per the Pacific data, which had 5-year overall survival of about 43%. We also have a number of neoadjuvant or perioperative chemoimmunotherapy studies in resectable stage 3 non-small cell lung cancer, which have shown PCR pathological complete responses of around 25%, and this is associated with significant improvements in disease-free and overall survival. So the most mature data comes from Checkmate 816, and that had in the stage 3A group 5-year overall survival rate of 65%, which is better than Pacific, but that's in a resectable stage 3A non-small cell lung cancer group. So what is borderline resectability? It's where it's actually where your MDT would say that the patient does not have resectable non-small cell lung cancer, and there is no actual consensus on what is the definition of resectability as per the EORCT surveys. But what we typically say is if it's T4 and or N2 or N3 disease, then that's not resectable. So this is a case series from 3 institutions, 2 in the United States, 1 in Italy. It's a multi-center retrospective cohort study, and it looked at the outcomes in patients who had been treated with neoadjuvant immunotherapy with chemotherapy and had T4 and or N2, N3 non-small cell lung cancer. The primary outcome that was looked at was pathological complete response rates, major pathological response, event-free survival. So the things to point out on this slide is that about 41% had PD-L1 high, was 2/3 adenocarcinoma, and in terms of the staging, 70% were 3A, a quarter were 3B, and about 5% were 3C. So 75% of patients went on to proceed to surgery after their neoadjuvant chemoimmunotherapy, and the pathological complete response rate was 29%. And you can see with the ribbon charts that downstaging with chemotherapy was almost universal. There were very few cancers that upstaged during their treatment. They also looked at subgroup analyses around smoking history, PD-L1 status, and KRAS mutation, STK11, and KEAP1 mutations, and tumor mutational burden. And it looked as though current or former smokers had a higher chance of PCR, PD-L1 greater than 50% had a higher chance of PCR, and importantly, if there was a KRAS mutation and an STK11 or KEAP1 mutation, there were no pathological complete response. So it looks like that might be a predictor of not getting benefit. And also, if the PD-L1 was low and the tumor mutational burden was low, that was another negative predictor. So this is the event-free survival and overall survival. The blue is those who had surgery, and the red is those who did not complete surgery. And those that didn't complete surgery typically had radiation or chemoradiation. I've tried to do a 2-year event-free survival rate is about 65%, and the 2-year overall survival rate is about 85%. Now, I've done that because they've said the median event-free survival is 52.6 months, but you can see that that's because there's sort of 3 or 4 patients that went on the study in 2018 that are skewing the data a bit. So there was another chemoimmunotherapy for unresectable stage 3 non-small cell lung cancer abstract called the PANDA-1 study. I don't think I have time to present it. It was an unusual study in that it was a single center Chinese study and it was a small number of patients. About 80% of them were squamous, 90% of them were smokers, and it had exceptionally good downstaging and resection responses. So I do encourage you to have a look at it, but I'm just not sure what to make of it yet. So in conclusion, with borderline unresectable stage 3 non-small cell lung cancer, it's a very important clinical scenario that we encounter probably quite often as a group. And what we've seen is very encouraging clinical trial outcomes, from this study. And there may be some patient selection factors. So I think these limited data support that there might be some clinical equipoise in development of prospective trials in this space. So that's something to think about.
Thanks so much, Tony. That was a huge breadth of data to get through. So small cells confusing, borderline resectable non-small cell lung cancer is confusing, and lots of things that we'll unpack in our discussion. We might move to Dr. Neil Wallace. So Neil is a radiation oncologist at the Peter MacCallum Cancer Centre in Melbourne. His role includes both clinical research alongside his clinical work, and he completed his specialist training in radiation oncology in Ireland. So thank you so much, Neil, for taking us through some radiation highlights.
Thanks very much, Beck, and thanks to the TOGA team for the invitation to speak this evening. So I'm going to take you through 4 different abstracts I'll aim for, 4 different settings, all with relevance to us as radiation oncologists. The first in the setting of unresectable stage 3 non-small cell lung, the next will be in limited stage small cell lung cancer. Then we have one in the setting of ALK-positive disease, metastatic or recurrent, and finally non-small cell lung, which is oligoprogressive. So to start off with EA5181, this was a phase 3 trial from the binary sessions, concurrent and consolidative durvalumab versus consolidation durvalumab alone for unresectable stage 3 non-small cell lung cancer. So the trial design here was, let's say, 660 patients here, randomized to the control arm, which is our standard of care platinum doublet with concurrent radiotherapy 60 gray, followed by consolidation durvalumab at the expected doses. Control arm was the same thing with the addition of concurrent durvalumab 750 milligrams weekly during the course of chemoradiation. Overall survival is the primary endpoint for this study. In terms of baseline demographics, I won't labor this because it's as we would expect, about 60% male, median age 67, but the vast majority current or former smokers, and 82% had carboplatin as their chemotherapy drugs. So in terms of results, primary outcomes, overall survival, there was absolutely no difference in overall survival seen, and likewise no difference in progression-free survival. In terms of absolute numbers, saw median overall survival in the region of about 40 months with both arms, progression-free survival in the region of about 15-16 months. So no difference between arms. The group presented some forest plots looking at potentially predictive factors for anyone who might do better with the addition of concurrent durvalumab, and there were none. That's on the left side of the forest plot. The only thing they highlighted was maybe the small numbers with cis-PEM actually did better with chemoradiotherapy alone, but again, with small numbers, they didn't really feel that that was relevant. And of more importance, definitely nobody doing better with the addition of concurrent. In terms of adverse events, reassuringly, there was no increased rate of any sort of adverse events really noted with the addition of concurrent IO. So whether it's low grade, high grade, or even treatment discontinuation, no obvious difference between arms. And so in conclusion, for EA5181, no difference in overall survival or progression-free survival with the addition of concurrent immunotherapy to current standard of care Pacific regimen. There will be future projects arising from this data, looking at toxicity analysis and local and distant recurrence factors and other things in relation to prognosis related to ctDNA. So take-home message from this study is there's no survival advantage to concurrent IO. It's conclusive proof given to the control arms, the current standard of care Pacific regimen in contrast to Pacific 2, and Pacific very much remains standard of care for unresectable stage 3 non-small cell lung cancer. So moving next to limited stage small cell. So we had another phase 3 randomized trial from the plenary sessions. This was hypofractionated versus conventionally fractionated radiotherapy, along with concurrent chemotherapy for limited stage disease. So in terms of background, our radiotherapy standard of care is 45 gray, 30 fractions twice daily for limited stage small cell lung cancer. But for logistical reasons, we frequently opt for a once daily fractionation. We have a couple of different options for that, 66 gray and 33 fractions, 70 gray and 35 fractions being two of the trial proven ones. So what this study did was it took a multi-center, open label randomized phase 3 trial across China, patients with limited stage disease, performance status 0 to 1. They had 4 to 6 cycles of the usual platinum etoposide chemotherapy, and radiotherapy would start no later than the 3rd cycle of chemo. And the randomization was to conventional radiotherapy at a dose of 60 gray and 30 fractions, with the experimental arm of hypofractionated radiotherapy, 45 gray and 15 treatment fractions over 3 weeks. Plus minus PCI, and primary endpoint here was 2-year overall survival. So the population recruited, and so median age, late 50s, over 3/4 were male. Only about 70% were smokers, which probably contrasts a little bit with what a lot of us probably see in the clinics. The vast majority ECOG 0, which again may be fitter than the average that we might see. About half had prophylactic cranial radiation, but no notable differences in baseline characteristics between the groups. So after a median follow-up of 43 months, your median overall survival conventional radiotherapy was just under 48 months versus 40 months with hypofractionated radiotherapy. However, when it's looked at each of these individual time points, 1 year, 2 year, 3 year, 5 year, it's really very similar between groups. So not an obvious disadvantage to the hypofractionated regimen when compared with our 60 gray conventionally fractionated dose. In terms of progression-free survival, again, no real difference between groups. 18 months median PFS with conventionally fractionated radiotherapy versus 16.5 with hypofractionated. And again, numerically similar at all time points after treatment. Surprisingly, over 30% with 5-year progression-free survival, which seems reasonably high. In terms of adverse events, there were slightly lower rates of a couple of we've got grade 2 in the table on the left and grade 2 and above on the left and grade 3 and above on the right. So slightly higher, well not slightly, but higher rates of radiation pneumonitis in the conventionally fractionated group, 14% grade 2 or above versus 7.5% for hypofractionated. And for grade 3, just with low number of overall events, this wasn't statistically significant, but 3% events versus 1%. And the group did mention the increased lymphopenia rates with conventionally fractionated versus hypofractionated, although it's not clear how much that is of clinical significance. So in conclusion, it's a randomized phase 3 directly comparing hypofractionated radiotherapy to conventionally fractionated in limited stage small cell lung cancer patients. There was numerically similar efficacy with hypofractionated radiotherapy and arguably a slightly more favorable safety profile. And in the era of immunotherapy, this may warrant further investigation. So this was discussed by Professor Finn from the UK, pointed out a couple of issues with regard to the trial, like namely that, as I mentioned, that population was probably a bit fitter than what we normally see, with quite a relatively high percentage of non-smokers, a lot of ECOG 0, and the overall survival was actually quite impressive at over 40% at 5 years, which contrasted quite well to a previous hypofractionated study from Canada, which had it at about 26%. This is previously looked at. It would have been nice in the context of hypofractionated radiotherapy. One of the real benefits is often the convenience, but there was unfortunately no quality of life or health economic results available. So the take home from this is we don't change our standard of care, which remains the bi-daily 45 gray and 30 fractions if possible. But in selected cases, this may well be a useful option. You know, if there's logistical barriers to come for, if people need to come once a day and they can't come for, you know, a full 6.5 weeks, this could be potentially a useful option. I'll move now to the setting of ALK-mutated disease, and we have the Bright Star trial, which is brigatinib plus local consolidative therapy in TKI-naive, ALK-positive metastatic non-small cell lung cancer. So it was a single-arm study from the US. So we had patients with, as I say, TKI-naive, ALK-positive disease, performance status 2 or less, and they had to, well, and they'd have at least one side of residual disease, which would be amenable to local consolidative therapy. So they started with 8 weeks of brigatinib, then were restaged, and as long as they didn't have progressive disease, continued with brigatinib and had local consolidative therapy. If there were fewer than 3 active sites of disease, then this was delivered to all sites of disease. If there were 3 or above, it was as per physician discretion. And brigatinib will be continued until disease progression or unacceptable toxicity. Primary objective is safety and tolerability of brigatinib. We will also present the progression-free survival data. Patient characteristics, there were 34 patients involved, wide median age, 60% female. And in terms of that question of the number of metastases, so 3 or fewer was 18%. So these are the ones who would be obliged to have consolidative therapy to all lesions. And for 82%, it was all at physician discretion. 80% had had a partial response to brigatinib at 8 weeks, and 20% were stable. So what was the local consolidative therapy delivered? 80% radiation, then 89% surgery, some had both, and 1 patient didn't end up with any disease residually, which was amenable. 1 patient withdrew consent. 62% had comprehensive, so ablation of all disease residual, and this should be 38%, but 12 patients had partial local consolidative therapy. And within the radiation details, actually, most of it was IMRT or VMAT. Only 8 of these were actually SBRT. Brigatinib was usually held during radiation, but not always. And again, a handful of patients had a surgical procedure, whether it be lobectomy or adrenalectomy or sublobar resection. So the primary endpoint was safety. So grade 3 and above adverse events. There was 1 bronchopulmonary hemorrhage, and there was a few grade 3 events, one of which was a grade 3 pneumonitis necessitating switching to alectinib. And this patient, the authors noted, continued without evidence of progressive disease. So in terms of progression-free survival, this was quite good. The 5-year progression-free survival was just about 51%, so 66 months median, which is quite impressive. It's a single-arm study, so they used a historical control. They compared it to the ALTA-1L study, and here we had at 1 year, 2 year, and 3 year, 94%, 81%, and 61%. So favorable with historical control, but obviously this isn't randomized data to directly compare. They broke it down based on a few potentially predictive factors. So based on local consolidative therapy extent, those who had comprehensive did much, much better. This probably makes sense. They on average have fewer sites of disease, so it's not that surprising that their PFS was better. Like a lot of the people in the partial group just had untreated disease left there, so it's not a surprise that they progressed. And similarly, based on total volume, if you had lower volume disease, you're on the blue line, you're also going to have better PFS. Baseline ctDNA or RNA positive, again, more likely to have a shorter PFS. And the fewer organs you had involved, again, potentially less likely you were to progress quickly afterwards. In terms of univariate and multivariate analysis, then the few things were positive on univariate analysis, including the things we saw on the previous capital markers, but ctDNA status, the number of organ mets based on total volume. This is the sum of longest diameters based on SLD of the progressive lesions. And finally, the comprehensive local consolidative therapy. And that was the only one that remained positive on multivariate analysis. In summary from that study, it does appear to be safe and feasible to deliver local consolidative therapy to patients with metastatic or recurrent ALK-positive disease. It may improve PFS, but we don't really know that without randomized evidence, and comprehensive does appear to be favorable, but with the caveat that that was probably a population that may have done better anyway. And finally, I'll quickly run through this. It's an exploratory analysis from the CURB randomized trial, which this is looking at tumor burden metrics at oligoprogression and survival after SBRT. So this is an exploratory analysis from that study. So by way of background briefly, the CURB study was a randomized study looking at oligoprogressive non-small cell lung cancer and breast cancer, and demonstrated a PFS advantage to SBRT in the setting of oligoprogressive non-small cell lung cancer. So the question that this study was asking was, could we predict which patients were most likely to get a benefit from SBRT in the setting of oligoprogressive non-small cell lung cancer? So they wanted to look at several potential candidate factors. So here they were: total number of growing lesions at the time of oligoprogression, total number of lesions. Then there were these ones: the sum of longest diameter of all lesions, of growing lesions, or of stable regressing lesions. So I'm not going to go through at length, nor did they at the conference, we'll have to wait in the paper for all of these. But what I will run through, the candidate metrics, outcome-based filtering, and then they would define metrics of greatest impact with the hypothesis that some particular super burden metrics at oligoprogression may have different prognostic values after SBRT. So what I will look at is the one that was positive, which was the sum of longest diameters of growing lesions at the time of oligoprogression. And what they identified here was this progression-free survival on the left and overall survival on the right. If your sum of longest diameter of all your growing lesions at the time of oligoprogression was less than 4 centimeters, your PFS and OS were both better than if that sum of longest diameters was greater than 4 centimeters. And again, univariable, multivariable analysis for that. Top is progression-free survival, and that was statistically significant for sum of longest diameters. So then at the bottom, we've got overall survival. Prior lines of systemic therapy was also predictive of overall survival, and the sum of longest diameters of the growing lesions was. You can see they did check all the other ones, total growing lesions, sum of longest diameters of all lesions, and they weren't positive. So it's potentially interesting data. Finally from that, this may be a good predictor for PFS after SBRT, and maybe better than things like just total number of lesions. But when you're assessing lots of things like this, the possibility of a false positive is definitely there. So that's summarizing it all from a radiotherapy point of view. How is this conference going to have changed our practice? The plenary trials really validate what we do now. Pacific's still standard of care for unresectable stage 3, and we don't have reason to change our standard of care for limited stage, either 45 gray and 30 fractions BD, but the presented hyperfractionated approach may be an option for selected patients. Local consolidative therapy has a role potentially in prolonged PFS in advanced ALK-positive disease, and some of longest diameters is interesting and may prove to be useful for us in terms of making clinical decisions for SBRT. I'll just finish briefly with a plug for the IASLC Academy for any early stage, early career researchers. There were 2 Australian mentees, myself and Jing Ho from Queensland this year. It's a fantastic opportunity to get involved with international collaborators, get mentorship from international experts, including Ken O'Byrne from Australia as well, so a few representatives from this part of the world. So there's the link. Go onto the IASLC website. The applications are open for another 6 weeks, so definitely highly recommend. And thank you very much for your attention.
Thank you very much, Neil, and congratulations for being part of the Academy this year. We might move now to a discussion with all of our presenters tonight. So hopefully you can see us all on the screen. Mel, I might start with you because I think FLAURA2 was a real headline act this year at World Lung. So I think the first line treatment space is looking, busier now for EGFR mutant lung cancer. We've got Aussie monotherapy, FLAURA2, potentially practice changing, practice affirming for some, versus Mariposa. And I know we have reimbursement and access issues, but could you sort of take us through what you might be thinking in terms of treatment selection for a newly diagnosed advanced EGFR patient?
Great. Well, I think in the first instance, Beck, the Mariposa schedule, as you know, is difficult for us and the cost is prohibitive. So I'll cover the FLAURA2 plus Mariposa second. So the question is an Aussie monotherapy versus the FLAURA2 approach. So, as I showed, it's all comers that actually have a significant overall survival benefit. So for me, it's affirmed, what we've been building to in the last year, that I actually consider FLAURA2 for everyone, and then have a discussion around, the patient preference, the downfalls of, potential more toxicity, more time at the hospital, what it is they want to achieve, obviously, from their treatment and sort of that more intense 3-month induction. But I think it's going to be a minority, moving forward that we proceed to osimertinib, monotherapy with, and they're going to be, as you would expect, the older individuals, the poorer performance status, and those who just don't want to do, potentially more toxic treatments. Those are the exon 19 better prognostic groups maybe that are older. But yeah, I think it's actually my default position now, Flora-2. Mariposa will be interesting once we see the mature overall survival, what it looks like in months, because, you know, then that might really make us think. I didn't show you, but the Mariposa's overall survival curve is starting to flatten out. And I think we're a bit intrigued by that with regards to the immune modulatory effects of AMI. So Flora-2 versus Mariposa will be the discussion we're probably having this time next year.
Yeah, really exciting. And I think, you know, we have to take note of like toxicity profile. You know, there was somebody who asked a question at one of the presentations, who was a person living with EGFR mutant lung cancer, talking about her experience being day and night in terms of toxicity, being on chemo versus Aussie monotherapy as well. And, you know, when I look at Mariposa and I look at Cocoon, the, you know, kind of the 4-part regimen is fairly extensive, isn't it? But, you know, I'll be excited to see how this plays out. And as you say, like longer or a numerical value on that median OS for Mariposa.
Just a brief point to that. I think it's a really good point, Beck. I mean, it's open, right? So there'll be a group of people who will start with the combination approach and then we may stop, right? And they might continue on osimertinib, or if it's Mariposa, the lazertinib portion of it. So when I'm counselling individuals, I kind of say, if it's not working for you, you know, we can de-escalate. Because you don't know until you know as well.
And I think that sort of brings to a fantastic question that Vanessa Chin has asked. So talking about issues with neutropenia for people on Flora-2, you know, for some clinicians, they've been dose reducing osimertinib to 40 milligrams to keep giving the pemetrexed. Given what we've seen and maybe the importance of treatment intensity up front, should we be prioritising keeping the Aussie at full dose and actually stopping the chemotherapy? Thoughts?
Yeah. Yeah, that's what I do. I think the EGFR blockade is the most important part. So keeping the Aussie going is the absolute, you know, priority. We still don't know the advantage of the pemetrexed, and Daniel Tan did touch on that in the discussion. I liked that most people on the studies seem to stop Pemi early, but you know, more trials need to be done to look at how much it adds. But I've got a low threshold to stop the maintenance Pemi.
Yeah, and not for you to hog all the questions, but you know, obviously it's a kind of changing space for a lot of us. So Tim Clay's asked, many new phase 3 studies in the stage 4 EGFR mutant space still proposing single agent osimertinib as the control arm. Is this ethical given Flora-2 and Mariposa? Thanks, Tim.
Well, not now. I mean, I totally agree. I guess these are like our problems, aren't they, when crizotinib was the control arm for all our studies, because everything's moved so quickly. And we know those trial protocols weren't written yesterday. They were written potentially 3 or so years ago. But I agree. I think now it's the new benchmark is a Flora-2 Mariposa, you know, OS.
Great. Thanks, Mal. Andrew, I might move on to your presentation, which, you know, was quite heavily screening focused at this year's World Lung. And thank you so much for your, you know, talk. So I guess one question that's come through as well from Brian Chan is, Andrew, do you think that talent or the FANS criteria for lung cancer screening might one day be used in Australia in certain ethnic populations or those with a minimal smoking history? So perhaps a risk prediction model version 2.0.
Yeah, thanks. I mean, it's a really good question, and it's something that continues to be asked. I think one of the main criticisms of screening this population is a lack of randomized data. So, you know, the existing screening programs we have are based on large randomized controlled trials showing mortality benefit, and even Talent was a prospective cohort study, so not a randomized trial. So you don't really have data on overall survival or mortality benefit in this group as yet. The other criticism is overdiagnosis in this group. So you do have a high rate of cancers being diagnosed in screening that non-smoking group, but a lot of those are in stage 0, so minimally invasive, or adenocarcinoma in situ that potentially may never have caused any problems. There's risk of then complications from diagnostic procedures in those patients that were never going to progress as well. So I think there will be a role potentially in time. I think it's well in the future at this stage. Even the US FANS criteria is still in a study phase, and I think will be a long time before it's rolled out nationally because of those issues.
And you also presented some really interesting data on sort of the upper age limit of screening. So that was one of the plenary sessions, which showed, you know, comparable OS in older persons compared to younger if surgery was the treatment modality. So I guess as a respiratory physician, do you have any sort of, we almost have to screen the screened population, any particular questions or tests that you could run that, you know, might select out particularly fit older people, and, you know, maybe something that could be carried out in primary care where these patients will be identified?
Yeah, I think it's really challenging in primary care to try and work out who's potentially a surgical candidate and who isn't. Even in our own MDTs, you know, we have lung function available, CPETs, walk tests. We've seen the patient in front of us. And even sitting a patient in front of a surgeon, you still don't really know. So I don't think there's any easy tools to really know one way or the other. The authors of that trial are trying to put together a tool that can be used in primary care. Be interesting to see what they come up with. But as we know, you know, lung function's part of it. Comorbidities is part of the assessment as well. And probably the best test is just seeing the patient walk into the clinic in front of you, right? So I don't think you can replicate that in primary care, but a basic tool could be possible, but I think it'd be challenging to identify those patients at the outset.
And I think, you know, some of your other presentations sort of highlighted the gap that we have in our sort of Australian lung cancer criteria and what might be happening internationally as well.
Yeah, absolutely. And, you know, you can see internationally we have multiple different age criteria used, and multiple different screening criteria in terms of risk predictive models versus categorical models. And that's despite really only having 2 landmark trials that all of these screening programs have come from. So a lot of it comes down to cost effectiveness and government's willingness to spend, and background epidemiology as well. So I'd anticipate in the future our criteria will probably be nuanced to some degree and adjusted like other screening programs overseas have. But again, that takes time and evidence to support that change.
Yeah, absolutely. So, Tony, I guess there's been a number of questions and a lot of interest in, you know, small cell ADCs, and Michael Krasovitsky has put in a question. So it's exciting that small cell is getting this confusing. So I'm glad that's not just me. And it appears that tumor expression of DLL3 doesn't make a huge difference in terms of response rates to like tarlatamab and, you know, potentially DLL ADCs. Is that similar with other agents, and specifically ADCs?
Yeah, it seems to be. It's a good question, and I think part of the issue is these are selected because they're highly expressed in small cell lung cancer. So it's often not the case of like one person has 100% expression, the other person has 0. And there's always a lot of heterogeneity with these things as well. The other thing that we didn't really touch on at all, but there's probably an element of sequencing and what prior treatments people have had, as well as mechanisms of resistance and change in the tumor biology that might play a role. And I think a lot of the trials have used IHC as the way to screen for biomarkers, but it might be that RNA expression via more complicated processes or multiomics is better. And I think there's a lot of work to be done, and it's going to be tricky because everything's just going in 5 different directions all at the same time for small cell lung cancer, which is a good problem to have.
It's a good problem, it's a confusing one.
Yeah. And I guess going back to Tim's question about what standard of care do you use, a lot of those ADCs that are now moving on to their phase 3 randomized study in the second-line setting are comparing to, you know, topotecan or irinotecan, and if they're lucky, lurbinectedin, but none of them include tarlatamab or other DLL or other T-cell engagers. Yeah.
Great, thanks, Tony. And in our last sort of 30 seconds, I wanted to ask you, Neil, so that phase 3 study of sort of hypofractionation versus conventional RT and limited stage small cell, I mean, the discussant sort of raised that neither was standard of care. I guess what I've seen around the country is a real variation of those using like BD radiotherapy versus like conventional, but we haven't seen any studies that have shown conventional is superior. Why is there is it just resourcing? Is that why it's so difficult to run a BD fractionation schedule?
Yeah, we still do try to do it where possible. Resourcing is usually there. It means patients come twice a day, 6 hours apart generally. It's often just the patient population is not well enough to comfortably come twice a day, so it could be something as simple as that. There are some concerns over maybe a slightly worse esophageal toxicity as well, and again, it's often very central disease. So they're probably the two biggest barriers to it. And like you say, once daily hasn't been proven superior. That's what Convert looked at. It was, once daily to a high dose was not superior to this. So we're still left with this twice daily regimen as standard of care. There have been a couple of phase 2s recently looking at dose escalated twice daily. So we'll wait on phase 3 data on that. But I think we're still stuck with with BD as our standard of care. But for practical reasons, a lot of us are still going to use once daily quite frequently.
And then the hyperfractionation trials will come along.
Yeah, and for people who are even frailer, I guess, and find it even harder to come for the long periods, they're the ones we'll potentially look at that for.
No, thank you. And thank you everyone for participating in our discussion, and everyone online for sticking with us on a Tuesday evening. We might wrap up tonight, and for any reason, if you'd like to watch this again, this will be available on the TOGA website, and you'll get an email link tomorrow. We'd like to thank our sponsor again, Pattison, for their support tonight, and I'd like to extend a huge thank you to all our presenters this evening for their insights. We hope to see you soon at either a TOGA event, listening to the podcast, or social media if you're that way inclined. And thank you very much and good evening.